Good morning, everyone. Welcome to this second day of our annual meeting and our first plenary session. We've called it Training in Cardiothoracic Surgery, but it's actually more about transforming the care that we deliver. And we're going to run through those talks, and then we've got a long session of questions and answers. It's really important that we're able to take your questions, hear your concerns, hear your suggestions. Before we get into that session, I just want to take the opportunity to announce the INSQ Fellowship winners. I'm really grateful of Mr. Srinath Rathnam, thoracic surgeon at Leicester, who has been the education lead for the Society with Carol Tan. He's done the job for 5 years now, 5 years of organising all the courses, leading our education programme, and has done an amazing job. And on top of that, has organised the INSQ Fellowships. So I'm going to hand over to Shri now, just for a couple of minutes, so he can announce those successful fellowships.
Thank you, Simon. So we had a successful round of applicants, and there are your winners. So Vipin Mehta from Manchester, Cal Mondo, and Hazem Fallu are the consultant and team applicants. We then have 4 NTL prizes. We announced 2, but the caliber was so good, we convinced Mr. INSQ to award 4. We also have the Early Year Trainee Award, the Hospital Appointed Doctors Awards. Unfortunately, we didn't have anybody applying for the small grant, so we will encourage all the trust doctors to apply in the next round, which will be advertised very soon. Likewise, our AHP colleagues, although we had 6 advertised, only 2 applied and both were successful, and the medical students. May also take this opportunity to announce a new venture from the ACTS, which is the Consultant Academy, which has 4 leadership-themed masterclasses spread over a 6-month period. The details will be on our website. We're getting a specialist to come and teach our consultant colleagues. Hopefully, we will expand this to the AHPs and the trainees. Thank you, Simon.
Shri, thank you very much. We'll now get on with the talks, and I'll introduce each of our distinguished moderators before their talks. Thank you. Good morning, everyone. Welcome to this plenary session and talking about how we might consider transforming the care we deliver. We had our annual business meeting virtually in March, and we asked all the members who attended, and it was the best attendance we've had for an annual business meeting, if they supported the concept that the SCTS should write a toolkit to help units adopt enhanced practice. This is a 3 to 5 year strategy, and we were delighted that 93% of the members supported the project. Over the years, there have been incremental changes to the workforce and the care that we deliver. Each and every one well-intentioned and almost always demonstrating improvement. Units have adopted varying strategies depending on local need, resource and leadership. And this has impacted positively on patient experience. Allied health professionals have been able to progress their clinical career, and national appointed trainees and trust appointed surgeons have had more structure to their training. Some units have introduced changes that have increased the role of the allied health professionals more than others. We have some units that have allied health professionals delivering the service out of hours or with an on-call commitment. And there are also units that have made their middle grade surgeons non-resident on call. And at least one unit has implemented a perioperative physician. For the allied health professionals around the country, there is an inconsistent opportunity for clinical career progression. We have inconsistent titles and competencies and inconsistent remuneration and banding. And this is all associated with an inconsistent adoption of national framework for qualification and accreditation. And to some degree, there is a lack of clarity for indemnity and the scope of practice for these roles. Over the years, the NTNs have found that they have less access to theatre, 1 or 2 days a week. They have difficulty achieving sufficient cases on achieving their certification of training. They have decreased independent operator. This is where they do the surgery, but with a supervisor unscrubbed, but close by. And it is a quite dramatic fact that around 50% of their paid hours is spent holding the bleep out of hours at weekends and at night. This is 50%, which is largely not progressing their training, although it is important in their early years that they do get exposure to this aspect of our professional lives. It is interesting that this is a shared view across the surgical specialties, that in general, the craft specialties are not being able to give their trainees access to theatre in an appropriate way. This has been compounded by the fact that the curriculum has now been reduced from 8 years to 7 years, meaning that they have even less time to achieve their surgical skills. And if that wasn't difficult enough, we have now lost a year of their training due to COVID and less surgery being performed and often their redeployment to the COVID areas. These challenges are similar for our trust-appointed surgeons and doctors. They too have less access to theatre. They too have difficulty achieving sufficient cases for their Caesar applications, and they have decreased independent operating. And like their NTN colleagues, 50% of their time is spent holding the bleep out of hours at weekends and at nights. There is tension in the units around the country about who has priority for access to theatre time. There's a lack of defined job description for the non-surgical cardiothoracic doctor or the perioperative physician. What we have found from the units that have enhanced the roles of the allied health professionals is that the patients experience better care. They have more consistent care and they experience more presence of that care in the clinical areas. And also the feedback from our middle grade surgeons is that they appreciate the presence and support of the allied health professional in their training. So in the toolkit that we are writing, we are making the case for change, and we want to share the experience of units that have introduced the changes and describe the potential barriers and solutions. This will include role descriptions, competencies, rotas, remuneration, all to help other units that are considering introducing these improvements. And there's also a description how 24/7 cardiothoracic care can be delivered safely with non-resident middle grade surgeons. The toolkit's got some main chapters. Our lay representative, Sarah Murray, has written the patient experience introduction. Rajesh Shah, President-elect, has written about the extended surgical team. Possibly one of the most important chapters is the allied health care career progression, written by Bhuvana Biblaraj, our lead AHP. Tara Bartley, who is now the national lead for this enhancement and is currently the lead advanced practitioner in Birmingham and Brighton. And Helen Monday, who is our outgoing lead allied health professional. There's a chapter from the national trainees, from our trainee representatives, Abdul Badran, Duncan Steele, and assisted by the consultant surgeon, Jonathan Hyde, who is on the Specialist Advisory Committee. The chapter for trust appointed surgeons is written by the cardiac consultant surgeon from Glasgow, Zahid Mahmood. And there's also a chapter on the role and potential for the perioperative physician by Narain Majani, the Honorary Secretary for the Society. So the toolkit, it's not a one size fits all. Every unit will have its unique needs and will have its own solutions. But the overall aim is to show how it can improve patient care and patient experience, to give allied health professionals consistent opportunity for clinical career progression, that we are able to reduce the size of the middle grade tier of surgeons, and by doing that we can give equal and adequate theatre access to the national trainees and the trust appointed surgeons to theatre. we want to define the role of the non-surgical cardiothoracic doctor, the perioperative physician. At the same time, we cannot underestimate the challenge to introduce such change, especially in the face of restricted NHS funding. So it's a pleasure for me to open this session. We have distinguished speakers to talk about their areas of expertise. Professor Marjan Jahangiri, who's the chair of our Specialist Advisory Committee, responsible for national surgical trainees. Mr. Zahid Mahmood, consultant cardiac surgeon in Glasgow, who is the SCTS lead for trust appointed surgeons. Mr. Duncan Steele, who's a cardiothoracic national trainee and is one of our 2 excellent trainee representatives for the Society. And Ms. Tara Bartley, who's the lead advanced cardiothoracic practitioner in Brighton and Birmingham, who really is the national expert on how to progress allied health professionals in their clinical careers. I look forward to the session. I look forward to the questions and answers. Thank you very much. Good. Thank you. We'll move straight on to Professor Jahangiri's presentation, and we'll move through the presentations. And please, all of you listening, please ask questions. Think of the potential pitfalls that we're proposing with this toolkit. Think of extra possibilities that we haven't thought of. So we'll move on to Professor Jahangiri's presentation.
Hi, Simon.
Hi, how are we? Everyone, sorry, we're having a slight glitch with Marjan's presentation, which we're trying to sort out. So we'll move straight on to the next presentation, which is, I believe, Duncan and the NTN presentation.
So good morning, and thank you for the opportunity for this part of the session. I'm going to look at the changes in solutions in developing and enhancing the career progression of allied health professionals. So within this session, I'm going to have a brief overview of the roles, the service need and impact of different roles, the clinical skill sets and overall skill sets across the board, what training from an academic and clinical perspective is required, brief mention about the impact of the human resources from recruiting internally or externally, some brief mention about finance, looking at different models, and then seeing what the impact of creating career pathways for our AHP colleagues will do. I've put culture at the bottom there in terms of large letters. I do feel very much within our community and our society family, this is no longer necessary because it's very much a team working sort of move forward. But I think that the wider spheres sometimes in our organisations aren't quite keeping up with where we are. So we've got a disparate number of roles that we can look at, from the surgical care practitioner, well established since 93, advanced clinical practitioners, replaced to some extent clinical nurse practitioners, and that's mainly because they have now come from other professional backgrounds other than nursing. We've got advanced clinical practitioners in critical care and physician's assistants, and then of our allied health professionals we've got physios, pharmacists, radiologists, OTs, etc. That's not exhaustive, that list, there's others, but the key is that they have to have a professional body to be registered under in order to bring the roles to fruition. So the solutions are around looking at your current and future service needs and the skill sets to develop those, and identifying how the career development of colleagues can fit into a workforce transformation. So the challenge that I would caution everyone around is just remembering that our non-medical colleagues, nurses and allied health professionals, work officially a 37.5-hour week as compared to the 47.5-hour week. So when you're putting rotas together, that's important. I'll also add that obviously many of the allied health professionals work more than a 37.5-hour week, but the contracts are for that. So we're looking to provide a career pathway and also augment the rest of the training for our colleagues. Within this session, we're talking about that and how we can improve service delivery. Solutions sit within everything that we've done in the society over the years that's now, I'm pleased to say, echoed at Health Education England, Royal College of Surgeons, Royal College of Nursing, and is very much embedded in the NHS Improvement Plan of 2019. So it's about looking at what else is out there, both at local, national and international level, really. Skill sets, obviously once you've documented what skill sets you've got, what skill sets you're going to need, then your solutions are looking at what training can be put together in order to meet those needs pragmatically, but also for individuals. And it's a huge opportunity to move into areas that we wouldn't otherwise have practiced, and to capture that on, mini clinical examinations, DOPS, case-based discussions and multi-source feedback, etc. Very much echoes what's there in terms of the Royal College of Surgeons extended surgical teams now, and having a governance document to keep it all sort of, flowing in the right direction. Particularly important for training, because the challenges are around how you make sure you sustain the training relationship between the academic organisations, and then whether the job itself is just around service delivery, or it allows the trainee to have time to meet the 4 pillars of practice of education, research and audit, and leadership. So the job plan needs to reflect that. And in terms of solutions, that needs to be embedded, and all the documentation needs to be in place to demonstrate that. And I would very much point people towards the Royal College of Surgeons and the health education curriculums, which are hugely helpful these days and very much underpin a lot of the work that we've done previously. So challenges in terms of human resources. Now, this is a really interesting question, because a lot of the challenges are around not denuding our current workforce and having available people to go into these roles. But the key to this talk is around career opportunity. And if you don't offer career opportunity within your department, people will move on, or they will move out into other roles. So these advanced roles and development of AHPs are crucial for not only keeping hold of our talented people, but also creating opportunities for those coming up behind them to be able to develop into more senior roles, and making sure the support network's in there so that you don't have the attrition. This isn't really a time to talk about finances, but I think it's important in terms of career development to make sure that any workforce transformation project is underpinned by all the funding that you can now access through apprenticeship levies and Health Education England for supporting study. And then I think the solutions need to sort of look between sort of the organisation, the the department and the other wider opportunities nationally. So the alternative models that you can look at, just be wary that one size doesn't fit all. What can you do to ensure approved business plans go through to create these career frameworks? Well, be ambitious. Don't undersell yourself. Do go for the supernumerary model, because the career progression of these individuals is around getting the correct training, the correct foundations, so that they can then move forward to underpin development and further training of all our other MDT colleagues. Impact-wise, you know, looking at caseload and case type can identify which of the AHP roles would be best suited to you, or which group of them would be good. Looking at adverse events can identify where you perhaps could have done things differently and better. Looking at the stability of the service and which aspects need to have their secure foundations, and where you want to go with your service with these roles and how they can augment that. Don't forget to ask for patience, and don't forget to look at national targets and outcomes when you're trying to justify your own case for your own organisation, and utilise demonstrated key performance indicators. So look across the UK. There are many centres now where we have excellence that can be copied. So you're going to look to have a trainee position, you're going to look to have a qualified position, you're then going to move that qualified person into a senior position, and they can start to impact on the training of others. It's really helpful to have a lead position and give people a way forward for their career. And certainly Health Education England are now looking at some consultant roles. So the examples here are for surgical care practitioners and our advanced clinical practitioners, but there's also ones for a similar trajectory for our physician's assistants and our ACCPs as well. And remember, all AHPs can apply for these roles, but the professional body that regulates them needs to be on board. So the cultural aspects that I think we need to explore is, you know, let's not tie people to professional titles. Let's look at skill sets. Let's look at delivering care in a timely fashion, and let's look at demonstrating success in the centres where we can and sharing that with our colleagues, and then also influencing strategic vision and leadership throughout organisations to have key champions. And I suppose with that comes all the tenacity and robustness that you need, and the support from colleagues who are very much on board with this sort of development. And if we do this, then we're going to allow, you know, a better cardiothoracic society for all people in training and all career pathways. So my key message, take-home message in terms of success: do your preliminary work first, have a job plan that allows time for non-clinical time. Use all the interested key stakeholders to help with formulating your business plan, benchmark your data, and add in your KPIs and where you're going with your project. Have MDT engagement, have the infrastructure in terms of not only the job plan, the job description, personal specs, but also the infrastructure to be able to request diagnostics for these people. They don't want to enter into a career where they can't fully function. So if you have an IT system, then they need access to that. They need radiology on board and all the other diagnostics and specialities that we refer into. Get your secure education pathway set up and your relationship with your academic institution and your shared learning as to how those 4 pillars can be met in the formal and the informal ways, both for our trainee ACPs and for our qualified colleagues as well. Make sure when you do your recruitment and selection, you are very mindful of the transition of role and the need to move out of traditional roles and to function independently. Have a good governance structure. We have one we can share with you, and make sure that your leadership is solid, I think probably is the best way to summarize it. Thank you very much. I'm not sure if our chair wants to invite questions now or at the end, but I will wait to be informed. So thank you very much, and I would like to hand back to the chairs now.
Thank you, Tara. You're a lot more natural at doing recorded talks than I am, that's for sure. Excellent presentation. We're pleased to say we think Professor Jahangiri is fixing her IT, so we're moving her talk to the end. I will now press on with Zahid Mahmood's presentation. As I said in my talk, he's a consultant cardiac surgeon in Glasgow, and he's now the lead for the trust-appointed doctors with the Society. So we're looking forward to your talk, Zahid.
Thanks very much for giving me the opportunity to give a presentation on trust-appointed doctors' perspective on training in cardiothoracic surgery. Why there is need for change for trust-appointed doctors? Due to the limited training opportunities, ideally all surgeons in training should have equal access to theatre opportunities as well as other educational support. However, prioritization is difficult and challenging due to European Working Time Directive and units requirements. There is limited recognition of seniority of the middle grade surgeons in the delivery of service commitments. Many departments have all individuals are often on the same resident rota, irrespective of whether they are newly appointed or needing accreditation. Also, several precious hours of trainings are wasted in routine service, especially resident calls, when training opportunities are already limited. I will start with clinical experience and will suggest that for trust-appointed doctors, it should be a curriculum-based approach for training. An allocation of a clinical supervisor and educational supervisor along with an appraisal will help them to achieve their target on curriculum-based approach. It should also be focused appraisal with well-defined professional development plans for the trust-appointed doctors. And also a structured assessment of level of training and progression of competency in the specialty. The other area for the clinical experience is clinics and MDT. There should be a maximum of one outpatient clinic per week for the trust-appointed doctor and a minimum of one MDT per week attendance. There is a challenge on on-call commitment and how to cover the service requirement. There should be an opportunity to be off the on-call rota for trust-appointed doctors after success at exit fellowship exam. And also there should be opportunities to attend emergencies relevant to seizure competencies, especially aortic dissections, stridor or airway compromise, trauma, endocarditis, or massive hemoptysis. What are the perspective for trust-appointed doctors in their operative experience in the specialty? Improve operative opportunities in theater depending upon the phases of training, similar to NTM curriculum, which suggests phase 1 and 2, and the aim is to achieve 2 to 3 theater days per week as an average. How to achieve that? The use of perioperative physicians as well as allied health nurse practitioners and other SCS doctors, which include staff grade on permanent position, to provide the service provisions to allow the trust appointed trainees to attend theater sessions depending upon their level of training. Senior or post Caesar trust appointed doctor allowed to choose appropriate cases across different consultant operating list to build up on independent operating experience. Also, emphasis on achieving operative independence, particularly in their specialty, to ensure they are competitive for consultant post. The other area is also important for trust appointed doctor to assess the educational resources. During the time of their training in the specialty, they should be offered FRCS cardiothoracic exam courses and advice sessions, Caesar guidance sessions, and support for preparation of application, equitable access to SCTS education courses similar to NTNs, and professional development courses including leadership, communication courses, and advice relevant to specialty in order to improve patient safety. Also, the trust should encourage the trust appointed doctors to use their 30-day allowance to focus on gaining operative exposure or observerships in their subspecialty interest areas in other units in the country or outside UK. SCTS already provides with traveling fellowship and it's already been offered to trust appointed doctors to take that operative exposure and observership in their specialty interest areas. Also, recently, SCTS also launched Trust Appointed Doctors Mentorship Program, and that will give support to Trust Appointed Doctors in terms of their training opportunities to discuss about exam and to get advice on their Caesar's application. The trust appointed doctors can be approached by the mentors, or the mentors and regional advisors can be approached by trust appointed doctors for any professional advice and support. In summary, it's a challenging role for mentors as well as the mentees in trust appointed doctors, but in my view, that's the way to move forward to gain adequate operative experience, educational access to educational resources, as well as getting competencies to a consultant post. Thanks very much.
We reflect that the trust-appointed doctors are such an important group to our patients, to our teams, and we are trying to make up the fact that we've overlooked the needs of that group, and we hope we can catch up as quick as we can. Please, everyone, this is a challenging agenda. This is about adopting best practice from around the UK to help with our patient care, with helping with the training for our trust-appointed doctors and NTNs. There must be questions you've got, so please post your questions. We'll now move on to Duncan Steele's presentation. And as I said, we think we've sorted out Professor Jahangiri's presentation to follow that. So please put your questions in.
Good morning, my name is Duncan Steele. I am the Senior Cardiothoracic Training Representative for the UK and Ireland and an ST7 in cardiac surgery in the northwest of England after recently moving from London. I'll be talking today about the quality of training in the National Training Programme in the UK. Now, surgical training in the UK has a long history. Recently in Colchester, there were surgical instruments found in Emperor Claudius's residence there. We all know about Henry Suter's world first mitral valve intervention in 1925, and training via the apprenticeship model in the UK has long produced world-renowned surgeons which not only lead day-to-day clinical practice, but help change and evolve day-to-day practice. Many of the cardiothoracic surgeons in the UK now were trained in the UK system, although many spent time abroad too. Increasingly, we are seeing appointments to NHS consultant positions in cardiothoracic surgery from non-UK trained surgeons, and in the last 5 years or so, this has represented about 50% of appointments. This could reflect some deficiencies in our training in the UK. There's a long-standing commentary on the complex relationship that occurs between medical school, general public, and cardiothoracic surgery full stop. And there's good evidence to show that recruitment into cardiothoracic training has reduced in terms of the number of UK trained medical school graduates going into cardiac surgery. However, from my own experiences, there are some incredibly highly motivated, successful junior doctors and medical school students who want to go into cardiac surgery and thoracic surgery because they recognise it as an incredible specialty to be involved in. As training representative with my colleague Abdul as well, we often get approached because of problems. We see it when there's issues. Very rarely we see bullying, discrimination, power trips, and some of those negative things that can be associated with cardiac surgery. However, this is fleetingly rare. This year we've established the Trainer Awards, and this has allowed us to interview lots of people involved in training, and lots of people's opinions have been shared about how, quite frankly, incredible training is in the UK. We've seen some great examples of mentors, mentees, training in very difficult scenarios. However, it's very clear that the biggest danger to training in cardiothoracic surgery in the UK is apathy, ignorance, and a lack of engagement with the change. The world we live in and the world we practice in is very different than it was 10 years ago, 20 years ago, 30 years ago. Trainees themselves have different learning needs. Their education up to this point has been different than the consultants that are practicing now, and we need to recognise, engage, and evolve with this. So is UK training bad in cardiothoracic surgery? Well, the year I was appointed, cardiac surgery, cardiothoracic surgery was the most competitive surgical specialty at ST3. almost double the number of people per post than other specialties. The pattern of recruitment has changed, however, and increasingly we're seeing more competitive applicants earlier stage in ST1 recruitment, and this may reflect some of the contractual changes which have happened since 2016, and people wanting to cement their training and progress quickly. It would be negligent not to discuss COVID and its effect on surgical training in the UK. This graph shows surgery full stop and e-logbook entries, the elective procedures which form the mainstay of surgical training in the UK, plummeted during the first wave and the second wave, and this is closely reflected in numbers of training in cardiothoracic surgery as well. There are centres which have managed to alleviate some of these pressures due to removal of peripheral clinics, and actually there's some thoracic centres which have actually operated more as trainees. It is important to recognise, though, that the hangover of COVID-19 in terms of its effect on training is going to be long-standing, if not from a burnout point of view, a progression point of view, just from case numbers. Now, there are some systematic issues with the way training is structured in the UK. As far as I'm concerned, there are minimal, tangible, objective, financial, etc. returns for trainers. There is a lack of resource and manpower. Some rotas are very understaffed, which mean that a lot of pressure is put onto trainees to cover those rotas. One statistics which I hope will sit with you listening to this talk today is if you're doing a 1 in 8 rota resident on call, which is a system which really wasn't used 20, 30 years ago. Those trainees spend about 50% of their time in their 48-hour week holding the bleep, and that continues for the whole of their training. There are generational changes which mean that the way that we've worked in the past and the structures we've worked in hospitals were different, and we need to appreciate and engage with those differences and get around them to make sure that training still happens. Importantly, hospital infrastructure, on-call rooms, etc. don't really exist anymore, which means that the long hours, the intense operating that many trainees did previously just isn't possible. Now, myself and Abdul will cite lots of very, very good examples of training. We need to be proactive and flexible about how we approach training, and we need to learn about how it's been done well. Overwhelmingly, trainers in the UK are enthusiastic, willing to put themselves out to support trainees and progress them in their career. I know I'm probably speaking to the converted when it comes to this, but nurturing the trainees is so important because they are the next generation, and we can't just stand still. We need to change the historical mindset of learning by osmosis, just being hospital, because that's not going to be good enough anymore. We need to engage in active learning, set objectives from an early stage, and make sure every single day trainees are making significant improvement. We also need to be honest about what training is delivering and how we're going to deliver things. Technology will change the way we practice and train, and we've seen that due to COVID with telephone clinics, video clinics. Traditional doctor roles will be replaced with allied healthcare professionals, and we've seen damages to junior surgical training with endovascular harvest being taken over from SCPs, which means that surgical trainees in cardiothoracic surgery often don't quite have the dexterity and basic surgical skills which they perhaps did previously, and we need to compensate for this. It's important to end talking about some of the successes of cardiothoracic surgery training in the UK. It is the longest training programme in the world. However, an overwhelming majority of NTNs, National Training Number appointed trainees, go on to reach their CCT and successfully get a cardiothoracic job. There are reports and modelling to show that out of the 136 trainees that are going to leave the programme or in the programme at the moment, some of them will be without a consultant position in the future. However, historically, we've managed to cope with this workforce planning issue and continue to train surgeons so they are exceptional. This has meant that graduates of the programme, when they haven't been appointable jobs in the UK, they've gone elsewhere. They've worked in America, in Canada, in New Zealand and Australia. And despite any deficiencies in training and any of these perceptions that training in cardiac surgery or thoracic surgery in the UK is somehow poor, just look at the outcomes. Over the last 20 years, we've seen increasing complexity of patients, while the mortality rates and outcomes have continued to improve. And that's as we've been seeing trainees of the UK system go on to practice. And it's not just because of technical skills, it's because of the wider development of those surgeons and the ability to work in a team and deliver what is world-leading patient care. Thank you very much.
We're still having problems with Marjan's presentation, I'm afraid. So we are working hard to try and work on that. I'd like to say a few words, and then we'll move to Q&A. We are very fortunate in our specialty. We have some of the most enthusiastic, gifted, intelligent, talented colleagues, and it is wonderful to see the enthusiasm for our specialty. Richard Page always said as president he was impressed by the enthusiasm around him, and I absolutely see that. But there is a frustration, is that there is unequal opportunity around the country for allied health professionals, for trust-appointed doctors, for NTNs, and there are no easy solutions. But it is a little bit frustrating now, is because there are units that are making a difference, that are transforming their care, introducing great changes to their practice, and it would be good if we can make those changes. So good. So we've got Marjan's slides just appearing on the screen, which is excellent. We'll have to see if those come good. It is frustrating because, particularly for the surgical trainees, the trust-appointed doctors, the NTNs, these men and women, they're in their 30s. They are highly aspirational, and yet we are not able to give them the opportunities that they deserve. And if anything, we are undermining that professional status with calling them non-NTNs or calling them trainees. The way we assess them continuously, the way they're meant to be perfect, and any slip-up is a major blemish on their online formative assessment. And we need them to enjoy their work, to get training through every week, every month, and feel they're progressing. And the SCTS toolkit is to help units, help colleagues think what they can do in their unit to make a difference. As Tara said in her talk, and myself, there is no single fix that's going to apply to every unit. But we hope the toolkit will give examples that can be used to make a difference. So we'll move on to questions and answers. Are the other members of the panel able to start up their videos? Tara, Duncan, Zahid, can you come and join the session? Duncan, thank you. Tara, hello. Good to see you. Right, so we've got Narain is our questions and answers master, so I'll hand over to him.
Thank you. Zahid, also, if you could join us, it would be great. Thank you for all of you that have put in questions. As Simon said, this is a challenging agenda we want to put forward, but hopefully it will be great for all members of the cardiothoracic community. The first question has come through from Benjamin Omorugby. Excellent proposition, but trust and clinical leads should implement this fairly to all middle grades, both NTNs and trust-appointed doctors, and not adopt a middle ground where non-NTNs are made to hold forth whilst the NTNs are freed from being resident on call prior to getting the full complement of AHPs. Simon.
Thank you. I think Ben highlights where units have implemented a change, but at the expense of other colleagues. And it is understandable what's happened, but can you imagine the tension in those units where there's one group of middle grades being given preferential treatment and the others aren't? And as we discussed on the non-NTNs yesterday, it can be the opposite way around. Sometimes you've got trust-appointed doctors who are favoured by their consultants because they're very able in theatre, and it's actually the NTNs that are disadvantaged. So for every unit, we need to look at how we're looking after our middle grades and giving them equality of treatment and access. Duncan, Tara, have any comments on what you've seen in your units?
I suppose what I would say is that the middle grades that contribute toward the ACP training are hugely helpful and hugely informative. What you tend to find is you often get a good relationship across that sort of tier of working, which helps with the collegiate way forward. But if it's at the expense of individuals' training, then obviously that needs to be addressed. And I think the toolkit is looking to sort of put some guidance in for allocating, what sessions individuals should go to from their theatres. We've seen in some of the talks from their theatre slots, from their clinic slots, and from their clinical commitments in terms of service delivery for the inpatients. So I would suggest that that is a model to work towards. And then I think the other aspect is, there are those amongst us that prefer teaching. And then that's a really, really rewarding aspect. There's nothing like, finding out what you know or what you don't know when you come to teach it, and also for you to consolidate. And then that gives you an opportunity to then start to teach on the national sort of circuit for ourselves as well. So it can give you a huge portfolio. And although it's not in theatres necessarily, some of the wet lab opportunities and things as well. So I probably would say that, it needs to be fair, there needs to be parity, but there are lots of good opportunities, and you foster some very good sort of, professional relationships and experiences by working, across the MDT, especially when you have a training package for ACPs. And I wouldn't undermine the role of a lead in that as well, from an ACP point of view, in terms of augmenting the registrar's opportunities and the middle grades opportunities. And throughout the whole area, and also pushing it forward. Thanks.
Thanks, Tara. Duncan, what are your thoughts?
I think there are departments across the country where there's friction, and that's sometimes when things have been changed very rapidly and not necessarily seeing the big picture and how it's going to affect more people. I think if you're proactive and make some of these changes while looking at everyone's needs and having a chat and being open with the various middle grades, whether that be an NTN or a trust-appointed doctor, you can actually create a system that is better for everyone, rather than having to troubleshoot on a day-to-day basis. If you sit back and really look at the big picture when it comes to individual people in the department and what they're going to need. And as you mentioned in your talk, it's not a one-size-fits-all. A lot of the suggestions in the toolkit and a lot of the suggestions that you make on a daily basis, they need to be adjusted for each department, and each department in the UK works in a slightly different way. Each trainee, each trust grade doctor needs a little bit different experience and a different focus of their training. But from a personal perspective, I was taught how to talk by an SCP. I had a SCP, a very senior trust grade doctor supervised me doing 6 months of operating. We are the same team. That friction shouldn't be there, and it's very avoidable if we just engage with the whole process and make changes proactively rather than waiting for things to go wrong.
Simon, could I just also add to Duncan's comments there that I actually think you cannot undermine the role of the consultant body in this, both the surgical consultant body and our anaesthetic body. In the units where this works well, it is, a team approach. I can't sort of specify the support that's come from both Birmingham and Brighton, particularly for the sort of forging the way forward for the success of the teams there.
Yeah, thank you. Narain.
Thank you for that, Tara. I believe we may have Professor Jangiri's presentation to go live, so we're just going to try once more to see whether that works. Otherwise, we'll go back to the questions. Can we try and run the video, please?
Duncan, just while we're waiting, just to say thank you to the training committee led by you and Abdul for organising the Golden Heart Trainer Award, the Golden Lungs Trainer Award and the Silver Sternum. Anyway, we'll go to Marjan's presentation.
Move to the new curriculum, which will be implemented from August 2021. First of all, what is the SAC and what are its functions? The Specialty Advisory Committee advises the intercollegiate bodies on higher specialist training. It consists of a committee of about 20 members, where the regional representatives present. One or two of the trainees, registrars are present as representatives of the training body. The SAC communicates with the training program directors, some of whom are members of the committee, and it works closely with the Joint Committee of the Surgical Training, which represents all the surgical colleges and all the other surgical specialties. Generally, I find this very informative to see what's going on in the other surgical specialties. It discusses the regional training programs, has a rigorous quality assessment of each program twice a year. At times, it can discuss individual trainees, progress of the trainees, mainly through their training program directors and their quality assurance. It can discuss and approve out of program activity and completion of the certificate of training. It designs the curriculum and it makes sure it is implemented. It works with the Society of Cardiothoracic Surgery. For any of our registrars, trainees, how to get a hold of the rules and regulations around training. I strongly recommend to you that you read the Gold Guide, which is available on the ISCP website. It's a reference guide for postgraduate specialty training in the UK. It is written by the UK health departments and is published by Health Education England. It encompasses core training and the specialist training. Please read it. It has everything you need to know about training and its regulations in the country. The new 7-year curriculum is going to be introduced in August 2021. It was an 8-year program, which has now become 7. The easier way of looking at it is in 3 phases, 3 + 2 + 2. The first phase is core surgical. The second phase is cardiac plus thoracic. The third phase, again, is cardiac and thoracic. Congenital and transplantation surgery can be introduced after phase 2. The specifics of this I give you later, not today, but in the next 3 months, because we're aiming to introduce congenital and transplantation training for you from earlier phases of the training. The exam can be taken after phase 2. The aim of the SAC and your trainers is that at the end of the 7 year, the registrar will be a fully competent surgeon ready for a first-day consultant job. I hope that you'll find this diagram helpful. It shows these 3 phases that I described to you. The top line is the run-through, or if you like, appointment at ST1. The first phase has core surgical training and some basic cardiothoracic training. The registrars will have annual ARCP by their local deaneries, and then there's a main ARCP at the end of the phase 1. Phase 2 has cardiac and thoracic, and at this point a trainee can declare which one they wish to do. The exam can be taken at the end of phase 2, so 5 years out after your training. Phase 3 again has more cardiac or thoracic, transplantation or congenital. And at the end of the 7 years, it'll be the completion of your training and certification. The lower graph shows the uncoupled training, or if you like, training entry at the ST3 level. In the next 1 or 2 years, appointment at ST3 level going to be significantly less, and probably not at all within the next 1 year or 18 months. For the forthcoming national selection in February 2022, there will be ST3 appointments, but the year after we haven't decided, but I think it's unlikely. So I have this diagram or flowchart in mind. It is expressed differently in the latest version of the curriculum, so don't be confused if you see this. It's essentially the same. Yup, there is a lot to squeeze into the program. Their indicative numbers of operation around 250, but it is not the sole requirement for your certification. There are many other if you like, indicators and requirements for your certification. You need to make yourself very competitive. You'll be competing with the non-NTN's registrar, candidates coming from abroad, sometimes with more experience. So, as your trainers and with yourselves, how are we going to deliver this shorter curriculum? Particularly that there are more things to learn, but become more subspecialized. There is literature to read. You may wish to do some research, have a scholarly attitude, publish and pass the exam. There's a great deal to squeeze in. However, I strongly believe that your main skill is operative surgery. It is something which has been given less attention in recent years. This is what distinguishes you from other specialists in surgery and people in medicine. You're in a very highly technical and skilled area of surgery, and you need to obtain those skills. Up to recently, we were recommending for the registrars to be in theatre about 2 days a week. Some surveys have shown that you have not been able to achieve that, and it's been 1.5 to 2 days. In order to deliver the curriculum, we really aim for you to be 3 days in the operating theatre. Some of the ways to facilitate this is to, if you like, have the help of the allied health professionals to do some of the non-surgical and service areas of work. Generally, your training has been firm-based, but I think it's not adequate for one registrar to be allocated to only one consultant. This we hope it will be changed and becomes attachment to 2 firms. And to be less resident on call in your later years. It is important that all registrars know requirements of on-call and emergency services. It is mandatory and is part of the curriculum. I'm not going to discuss the workforce planning in detail with you, but overall there are 5 to 8 consultant positions every year which become available in the UK. And we have about 20 graduates with CCT, so there is a surplus. There will be more thoracic opportunities, but I'm not going to discuss the details with you. Hopefully I'll be in a position to share these with you by August. Regarding workforce planning, if you wish to see some of the figures in the last few years, I recommend that you read the Training in Cardiothoracic Surgery. How far is the other side of the table? This is an article that I wrote with my colleagues Jonathan Hyde, Paul Sadler, lead dean for cardiothoracic surgery, and Mr. Stephen Sui, vice chair of SAC. How to excel and make yourself competitive. Just be around a great deal. Take personal responsibility for your patients. You're fully qualified doctors, you're specialists, and show ownership of your patients. Take pride in technical excellence. Live and breathe surgery. You have to attend leadership courses, management courses, theoretical training, etc. Ward rounds. Do thorough workup of your patients and provide excellent post-operative care. At a recent talk to the thoracic trainees, I said, who owns the next of kin of their patients after surgery? I knew the answer, but I asked the question. I leave you to answer that question as well. Remember, the relatives waiting on the other side, wanting to know what's happened to the patient who's had major cardiac and thoracic surgery. Show that ownership. Some other points, learn the post-operative and ICU care. There's a great deal of physiology, which is necessary for your training. Please read one textbook, be it 1 or 2 volumes, cover to cover. Google handbooks, Instagram does not do. You must read the 2 main journals of our specialty, Annals of Thoracic Surgery and the Journal of Cardiovascular Surgery, every month. I assume, and wrong, I hope I'm wrong, not many of you do that. These are monthly publications, and please put 2 hours aside a week and read them. The curriculum stipulates that you have to have 2 presentations and 1 audit a year and 4 publications in your entire training. This is not a great deal. Have a scholarly attitude. Think of primary research and clinical questions all the time. So there is a lot to squeeze in. I hope I've given you some pointers and really show you that it is possible and that everybody who's involved in your training is committed to delivering the new curriculum for you and with you. Thank you very much for your attention.
Good morning. I'd like to discuss the future of cardiothoracic training and improve the curriculum, which will be implemented from August.
Nolan, for Tara, amazing talk, thank you. How can one access these toolkits or the resources that you've put together for the AHPs?
Tara, can you hear us?
Yes.
Just,
I couldn't before.
I'll do the question again.
No, it's not working. Simon, have you unmuted? Marjan's presentation is playing again, Simon. Duncan, can you hear me?
Yeah.
Can you hear the boys?
I cannot hear the boys.
Okay.
I could do briefly, but then they...
Yeah, that's right. So, Simon? Can we hear you? Yes? Is that thumbs up? We can't hear you. So Duncan and I have both got audio. I'm going to come off and come on again. So Duncan, can you hear the presentation?
I can hear you. That's it.
I can still hear Marjan's presentation in the background.
Okay, can you hear us now?
I can, yes.
Excellent.
Marjan's presentation is still playing in the background, but
Okay, we can't hear that. But we can do questions, can we?
yeah.
Excellent. Let's go.
Tara, this is for you again. I've said it the third time now. Amazing.
Oh, sorry.
How can one access the toolkit and the resources that you've put together? Because there's a fantastic amount of resources you've put together to help all the programs. So how can we access that?
Okay, so we've embedded all the bits and pieces either within the text of the toolkit that we're putting together across the whole of the sort of this presentation toolkit that we've done as a resource, and there's a number of appendices on there that will give the demonstration of those those particular bits. So if not, I'm happy for people to approach me on an individual basis. But Simon, perhaps we can come back to you on that, because the toolkit should be published soon, shouldn't it? And all the appendices are on there. So, but people know where I am if they need anything. I've had a few approaches already throughout the meeting.
Thank you, Tara. Yes, the toolkit should be in its final version in about 1 month. And that will be a resource for everyone on the SCTS website.
Next question from Hatem Nasser. The truth is that trust doctors are not recognised despite we talk about their training, the difficulties going through the very complicated CSER pathway, even if they are overqualified. Are there any changes in the future to the CSER pathway that will make it less complicated? Marjan, I don't know whether you're on line or not. Otherwise, Richard, maybe want to comment on that from an SAC perspective.
Yeah, thank you. I think the new CSER requirements will change, and they will change because the new curriculum is being implemented, and your application will be assessed against the new curriculum requirements, which goes live this year. I'm afraid it will, my understanding is, I think it will still remain complicated, and the advice is get the help of consultants who are involved in SAC, engage with the ISCP to maintain your portfolio, start early, at least 6 months to a year prior to going for the CSER application, and talk to colleagues who have applied for CSER in the past. SCTS is running courses through SCTS Education to help colleagues support the CSER process, etc. So there is quite a bit of help and support which is available. CSER requirements will change as the new curriculum gets implemented.
Thank you for that, Rajesh. In the interest of time, I'm just going to pick up some different themes. Andreas Kikas, thank you for setting up such a comprehensive toolkit to guide cardiothoracic training. As pointed out, given the frequently limited exposure of junior doctors in theatres, how do you balance the planned prioritisation in theatres between SMPs and SHOs?
Well, I'll start there, and then maybe Duncan can come in from his observations and training committee. We've got fixated on one surgical trainee per theatre, and that doesn't have to be the case. There are different aspects to every case which are applicable to the different members of the team. We've also got fixated on the firm structure, and it is possible to run effectively and happily a multiple team structure where surgical trainees are aligned to different trainers, more than one, so we can maximise the opportunities that we've got better. But the overall strategy is that we need to reduce the middle grade tier so that there is ample opportunity for all. Duncan, what are your thoughts?
Yeah, there's really two sections to this. There's the what can be done under the current system, and when it comes to utilising training opportunities in theatre, as you say, having one registrar there, one trainee there, whether that be a trust appointed doctor or an NTN, it's not the most efficient way of using the resources and using the opportunities, and there's significant improvement. And where this is done well, you can see ST1s, ST2s going to theatre, being supervised by another trainee, by either a trust appointed doctor or an NTN, like I did a few weeks ago, took someone through their first cannulation, and that learning opportunity itself is very valuable. Then the other side of the discussion is how you make departments less saturated with people who need those learning opportunities, and that comes under the whole toolkit and the whole restructuring of how departments work. Unfortunately, because of the way the work time directives affected things and a lack of change to the requirement to be on-call and resident on-call, means that there needs to be 8-10 registrars on each rota, even though you might have only 5 consultants, and therefore there's less pie to go around. And so there's two aspects of this: there's fixing the short-term bits, and then there's fixing the overall structure to improve things and less saturation of rotas and less saturation of departments.
I think the question was also around a bit of competition between SCP trainees, and I think there, Duncan said that he was taught by an SCP. I think there just has to be, a working that allows, people to move through in a sort of a equal fashion, really.
Yeah. It's not a them and us.
Yeah.
Thank you for that. Just taking some of the trust appointed doctors' comments all together, Indu Degla has actually commented that we've actually set up it's an equality and diversity inclusion survey, but it's also an opportunity for some of the trust appointed doctors to pass their comments regarding that. So she said the current survey uptake by trust appointed doctors and trainees is very low, and she would strongly encourage everyone to complete that survey. So if I could just reiterate that. So thank you very much, Indu, for that. Next question is from Anonymous. Can the Society encourage all consultants to ensure that in every surgical case, a trainee can participate actively and learn in each case? They should also resist the pressure from other staff members to rush theatre lists just so that everyone can go home early.
Can I comment on this?
Yes, please, Duncan.
So, as our president alluded to earlier, we did lots of interviews to award the inaugural Golden Heart, Golden Lung, and Silver Sternum prizes, and it was very interesting listening to a couple of cases where departments worked well. The consultant in the theatre had good relationships with the rest of the staff, and the overwhelming take-home message from the interviews that we did with from people in these departments was that if there's a good team structure, there's no big pressure on everyone leaving at 5 on the dot. There's an acceptance that we're in this together, we're a team, we're working towards a common thing. And what we found was that where departments work well and teams work well, there was no pressure on people escaping work. People were enjoying work, people enjoyed being part of the team. And it meant that trainees specifically, whether that be, again, trust-appointed doctors or NTN, were able to make the most of the opportunities. If the second case was more appropriate for training, if closing and coming off bypass was the most important thing for that particular case. So it comes under the whole system of fixing some of the issues that we've got in departments at the moment, and not just expecting everything to be perfect straight away. It's part of fixing how we work as a team, really.
Duncan, I'll just, Narain, just quickly. It's really important. Nobody wants to overrun day after day. Sometimes unexpected events happen and you have to overrun. But it is a team commitment to start on time and to finish on time as best you can. I always use the analogy of a football match. The referee does not turn up 15 minutes after the game started. And the WHO checklist is a demonstration of everyone's commitment to each other as a team, that you turn up at 8 o'clock promptly. It's about our professionalism. And then for the trainer, the anaesthetist and the perfusionist, they don't want to see the consultant trainer wander away and let the momentum go. It's about that presence, that enthusiasm, giving the training opportunities, but then being around to tidy up, to try and deliver the prompt finish. If you abuse the team, they just get fed up and they look to cancel the second case. It's about leadership and example, and it's an us situation. It's the team.
Next question, understanding some of the challenges that bringing in this toolkit will have on many units. Have you discussed what support you will get from NHS in England, Wales and Scotland to implement the toolkit? And
there's the challenge. There is the challenge. We've gone through a pandemic. We've spent vast amount of public money. The NHS is tired. It's got a backlog to overcome. And we are proposing a transformation on this background. It makes it even more difficult. Tara, you've been through some good times. What are your thoughts?
Well, I think you have to be savvy, don't you, really? There's an awful lot of national work going on, both in the Royal Colleges, both surgery, medicine, the RChem, the anaesthetics, the Royal College of Nursing, and then under the sort of spearhead of what's going on at Health Education England, the extended surgical teams sort of workforce transformation is top of the agenda. And if you can prove that you can have improved patient flow, improved training and improved attrition of your staff, and fulfill all the, the diversity, the happy at work side of things, then, the way in which you capture that on your business plan and your discussions within your organisation, they're going to find it quite difficult to argue against it other than the money. And if you can then come up with solutions from a money point of view, or at least, some offerings, then I think, it's about, just as I said, you've got to be tenacious. You've got to give yourself a good run up for it. It takes time. And you've got to use your interpersonal skills and networking to be able to, meet all the challenges in a constructive way. And a lot of what I write on a business plan is, let's benchmark this against the national data and the national standard. And you don't want to be sitting outside of that in terms of your organisation. So it's just, I suppose, clever use of wording, really.
Thank you.
Thanks for that. I'm going to put two questions together because they're on a similar theme. They're both from Anonymous. Should percentage training cases per institution be published in a similar manner to mortality outcomes in equivalent to a blue book? And then also, US training programs in cardiothoracic surgery publicly report their training data for all to see. This creates healthy competition between training programs and improves training for all. Can the SCTS and SAC please publicize the annual training data they receive from units?
Okay. Well, can I suggest, Duncan, have your response as NTN and then Rajesh as ex-chair of SAC?
So it's an interesting topic, and it's one that's come up before about whether all of the training data should be published. There are conversations behind the scenes in terms of proportion of cases done at different units, and definitely where departments are struggling to deliver training. This is one statistic that is often cited, however, not widely shared. I personally would be quite in favour of publishing this kind of data, and also at least collecting trainee mortality data. We're training to become consultants at the end of the day, and the scrutiny which our consultant colleagues have been under for the last 15 years is unprecedented, to use a word that's used too much at the moment. And I think having an appreciation of your outcomes is something which is fundamental to being a successful consultant. So I know it's something that a lot of my colleagues do, my trainee colleagues. Publishing it widely and sharing it on the internet like a blue book, I'm not sure there's a great deal of value of that. I think that would cause more problems than it would benefit, but I think sharing it widely as a surgical community would be potentially beneficial.
Thanks. That's a very good question. Number one, I think there is the GMC trainee survey, which is available, and it can be drilled down to the training program and can also be drilled down to the individual cardiothoracic department. So that's number one, which is out there in public domain. Number two, the JCST does a JCST survey, which is about 60 to 70% uptake, I think, in cardiothoracic surgery, which again asks various questions about training in our specialty, which is again available on JCST website. Number three is when a few years back, obviously, when I was chair of the SAC, we did develop individual quality reports, which had data from the JCST survey, from the GMC survey, the exam pass rate, and the SAC liaison report. And all this was compiled into an individual report, which was sent to individual program directors to share through the training committee, and which should ideally have a trainee. There was a lot of discussion at the time in the SAC as to how we should widely publish it or not. And I think we took the view that we didn't want to go down the route of a league table kind of thing, which we are all aware. There's some positive side, but there's some downsides as well. So the view that we took was to produce these individual programs quality reports, which was led by actually David Barron, and now currently being led by Sri Ratinam on the SAC. So the information is there, and that should come through the program directors and should be discussed within the training committee to facilitate improvements in your respective training programs.
Okay. And I think it's so important that the trainer and the surgical trainee is well matched, and that transparent data would help that matching. The time has gone quickly. It's 10:30. I'm sorry again that we had glitches with the IT. Duncan, very grateful to you and all your colleagues on the surgical trainees committee. You're doing a very, very good job, and you've had a very tough year. Tara, thank you very much for being here today. You've got your OBE for services to cardiothoracic surgery, and you've gone on from that award. And I don't know how you lead two teams and two outstanding units. And thank you for your contribution to our toolkit, because your knowledge is invaluable. So thank you very much. We'll get this toolkit published in about a month's time, and we hope that we're starting the conversations in the units. Any last words, Tara?
Just it's teamwork, isn't it, really? And I think that whole thing about being happy to come to work is really important, and valuing each other. We can't work in silos. Leadership.
Good. Perfect finish. Thank you, everyone. Thank you.
Thank you. Bye.